Hi, good evening, everyone. This time it's us logging in a little bit late with some technical issues this evening, related also to the fact that we have a lecture this evening from different continents, which I'm really pleased about. We have Professor Kummer from Cincinnati in the United States, and we have Professor Gosla Reddy from Hyderabad in India. So the combined time difference is about 11 hours, and I'm very, very grateful that both of you are sacrificing your time, and Gosla, in your case, even your sleep, in order to lecture for us this evening. So many thanks for that. So we'll get started straight away. The idea is that we split the time up in two parts. Professor Kummer will start with her lecture, and then we'll save our questions until Gosla's lecture, and then at the end, as always, we're very welcome to receive questions from our audience. So thank you everyone for being present for this lecture. Thank you, Anne. Thank you, Gosla. First of all, now for you, Anne, the floor is yours.
Okay, great. Thank you very much. Well, I really appreciate the invitation to speak with all of you tonight, wherever you are. This is my favorite topic to talk about, VPI, the speech pathologist's role in cleft care and VPI management. So I put a lot of information together for you, and I hope that this is very helpful. All right, I'm going to start by just talking about normal velopharyngeal function just for a second. So first of all, when we are breathing normally through our nose, what happens is the velum rests against the base of the tongue. Now, we don't feel it because there's no sensory feedback from the velum on the back of the tongue. But rest assured, it is there. And if it wasn't resting on the back of the tongue, then it would be difficult to breathe. So we want the velum to be all the way down so that we have a very patent airway for normal nasal breathing. But then during speech, what happens is the velum moves in a superior and posterior direction toward the posterior pharyngeal wall, and it has a type of knee action. Now, what I want you to notice is that the effective length of the velum is from here, the posterior nasal spine, to here, where it contacts the posterior pharyngeal wall. All right, so this is the effective length for speech. Now, I get the question a lot. Why is it that my patient with VPI has normal velopharyngeal closure for swallowing, but not for speech? Well, the answer to that is that during speech, the levator muscle raises this velum, and that causes that sort of knee action, that bend in the velum. But this part of the velum and the uvula would not be used for speech. In contrast, when we swallow, the levator muscle is not active. What happens is the back of the tongue pushes the entire velum up, including this area and even the uvula. And so it's a totally different mechanism. And that's why swallowing is not affected by VPI so much, but speech is. All right. Now I'm going to talk about components of velopharyngeal function. I like to say that there are three components. There's the anatomy. You have to have normal anatomy for velopharyngeal function, but it's much more than structure. Neurophysiology is also important because the velopharyngeal valve is dynamic, and the velum and the lateral walls are moving to achieve closure of the velopharyngeal valve. So that's coming from the brain, not from the structure of the velum. But there's even more to it, and that is articulation. So when a baby is first learning to babble, what happens is the child starts out with M sounds. So the child might produce the M sound repetitively, ma, 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 ma. You know, guess what? Mama is often the name for the mom, and there's a reason for that, is because that's one of the first things that infants are able to produce. But then what happens is they hear different sounds and they sort of experiment with this. And so then around the age of 6 months, you start to hear ba, 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 ba. Now, the difference between an M and a B is not what we're doing with our mouth, it's what we're doing with our velopharyngeal valve. And so the B sound requires velopharyngeal closure, whereas the M sound is a nasal sound. And so the velum is totally open. And so the child actually learns by listening and imitating how to produce the difference between a nasal sound and an oral sound. And interestingly enough, just like some sounds or some children learn to produce sounds abnormally, and that's a functional issue, some kids learn to produce sounds in the pharynx rather than the oral cavity. And it may be unrelated to the anatomy or the neurophysiology. All right, so I was asked to talk about the role of the speech-language pathologist in the evaluation of VP function and then also in the treatment. So starting out with the evaluation, the speech assessment is done perceptually, and what we do is we have to determine several different things. The first thing that we need to determine is the type of velopharyngeal dysfunction and the probable cause. I'm going to talk more about that. The next thing is the type of resonance, and again, the probable cause. The third thing is the presence and the audibility of nasal emission, because that not only tells us about VPI, but we also need to know the type of nasal emission because that will tell us the size of the opening. The next thing is the presence of obligatory and compensatory productions. And then finally, we need to determine, based on some of these other things, the appropriate treatment of velopharyngeal dysfunction based on our findings in the perceptual evaluation and then sometimes with instrumental evaluation as well. All right, so let's go and talk about the type of velopharyngeal dysfunction. All right, just like there are 3 components of normal velopharyngeal function, there are 3 different types of velopharyngeal dysfunction. The first type is what we see with a history of cleft palate or submucous cleft, and that would be velopharyngeal insufficiency. All right, that's when there's abnormal anatomy. All right, the next type is velopharyngeal incompetence, and we use that term when there's abnormal neurophysiology. And finally, abnormal articulation is usually termed velopharyngeal mislearning. Now, why do we make this distinction? I mean, why don't we just talk about velopharyngeal dysfunction and call it a day for all of these? Well, the reason is that the treatment is different. If it's velopharyngeal insufficiency, we may recommend a treatment such as surgical correction. Velopharyngeal incompetence, we may consider a prosthetic device. And then velopharyngeal mislearning is speech therapy. So we really like to make this distinction when we're talking about velopharyngeal dysfunction. All right, so velopharyngeal insufficiency. This occurs almost always due to the fact that the velum is relatively short in comparison to the position of the posterior pharyngeal wall. And so you can see here in this very simple diagram that the velum elevates to the level of the hard palate, which is what we want it to do. So the mobility is normal. The problem is the velum is too short to reach the posterior pharyngeal wall. Now, because of the laws of physics, what happens is the air from the lungs goes through the glottis, the sound from the vocal fold vibration goes through the glottal closure, and then the air and the sound travel in a superior direction. Now, the law of physics says that airflow will continue to travel in the same direction unless something stops it. And so if we have complete closure here, then that airflow is going to be redirected into the oral cavity, which is what we need for speech. But if the airflow is underneath an opening, that airflow will continue to go through that opening and into the nasal cavity and be emitted nasally. The important point that I want to make is even a little tiny opening here can be symptomatic from a speech standpoint because the airflow is underneath that opening. Here's an example of velopharyngeal insufficiency. Here you can see the adenoids, here's the velum, and let's just watch and see what this child does.
I see the sun in the sky. I need a nine. She went shopping. We went shopping. I ride a choo-choo train.
That's swallowing. Total
60,
closure.
60, 60, 60. Okay, count from 60 to 70. Go 60, 61. 60.
I love working with kids. Now I want you to see what happens when he uses or produces one sound only. Okay, it's different, right? Okay, one sound, he gets much better closure, but what happens is now we don't hear the sound going through the nose, we hear the bubbling of the secretions. All right, some of the causes of velopharyngeal insufficiency, of course, a history of cleft palate or submucous cleft, a deep pharynx due to cervical spine anomalies can cause velopharyngeal insufficiency. Irregular adenoids can prevent the velum from achieving a tight seal against the adenoid pad. A tonsil in the pharynx can interfere with lateral pharyngeal wall motion or even interfere with the velum by getting in between the velum and the posterior pharyngeal wall. And of course, certain surgical procedures, adenoidectomy, maxillary advancement, and tumor removal can cause velopharyngeal insufficiency. Now, what about velopharyngeal incompetence? Here we have a normal velum. It looks like it's long enough, but it doesn't have that nice knee action. So that is due to a neurogenic disorder. So this is what we would see through lateral fluoroscopy. Here's the velum. It's plenty long enough to do what it needs to do, but we've got a big opening here.
I like this cola, but I don't like cheesecake. But I don't like cheesecake.
Okay, so some of the causes of velopharyngeal incompetence include head trauma, cerebral palsy, CVA, and different neuromuscular disorders that you can see here. Now, finally, velopharyngeal mislearning. This is, there are a lot of different examples of this, but the one I want to focus on is when there's phoneme-specific nasal emission. And this occurs when the articulation of what we call sibilant sounds, the teeth sounds, S, Z, SH, CH, J, all of those different sounds, one or all of them can be produced in the pharynx as a type of sound. So when the sound is produced in the pharynx, what will happen is that you're going to have nasal emission.
Say pop, 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 pop.
So we've got total closure here.
Tap, 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 tap. Say cock, 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 cock.
Total closure, the velum looks normal, everything's great.
Cha, 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 cha.
No problem. Okay, so that's due to misarticulation, and that can easily be corrected with speech therapy. I've had kids refer to me for a second opinion about VPI surgery, and I found that this is what they have. They have phoneme-specific nasal emission, and when it occurs on all those sibilant sounds, you would assume that the patient has VPI. It takes a speech pathologist to identify the fact that this is not a structural problem or even a neurophysiological problem. It's actually a misarticulation that can easily be corrected with speech therapy. All right, so causes of mislearning, one is actually hearing loss or deafness, but also compensatory productions due to VPI, where kids produce the sounds in the pharynx rather than in the oral cavity, because in the pharynx they have airflow to work with. And this can be just mislearning for no reason, no structural or neurophysiological reason. All right, so with velopharyngeal dysfunction, especially with the VPI, either insufficiency or incompetence, can cause these following things. The first thing is hypernasality. Hypernasality is a resonance disorder. Resonance is the sound that we have during speech, and you hear it on vowels and voice consonants. The other thing that we might find with velopharyngeal insufficiency or incompetence is nasal emission. This is really a speech disorder because what it does is when there's nasal emission, there's less airflow in the oral cavity to produce all the pressure sensitive consonants. And when there's nasal emission, there are often obligatory distortions or compensatory productions, which I'll talk about later. And even dysphonia. There's research that shows, and in my clinical practice, kids with VPI who are trying really hard to get the velopharyngeal valve closed, they also have tension in the vocal fold area, and they're prone to have vocal nodules. All right, so now let's talk about the type of resonance and the probable cause. All right, now I'm going to define vocal resonance. So vocal resonance is defined as the quality of the voice as distinct from pitch and intensity from phonation that occurs when certain formant frequencies of the phonated sound are selectively enhanced based on the size and the shape of the cavities of the vocal tract. All right, now resonance disorder, therefore, is due to abnormal transmission of the sound energy in one of the cavities of the vocal tract, and that would be oral, nasal, and pharyngeal cavities, and this occurs, of course, during speech production. All right, so the one that you're probably most familiar with is hypernasality. Disorder. My articulation is perfectly normal. All right, now with hypernasality, it's going to be most perceptible on vowels. Why is that? Because vowels are resonant sounds. So let's say that I start to phonate, I go, ah, okay, that's the source, my sound in my larynx here, okay? But I'm gonna modify that sound as it comes up through the pharynx and into the oral cavity. I'm gonna modify it by modifying the shape of my oral cavity. I, E, U, O. So I'm manipulating the resonance in the oral cavity so that there's a different acoustic product that you hear as a vowel, all right? Now, another thing I want you to notice, the volume of the speech is reduced. Why is the volume lower when there's hypernasality versus oral speech? The reason for that is as the sound travels up through the pharynx, there's spongy tissues there in the pharynx and then also in the nasal cavity. And this spongy tissue absorbs some of that sound. In addition, because of the laws of physics, if you have a big opening, like say a big mouth opening, you're going to have more sound come through there. So like when you yell at somebody, you open your mouth really loud. If you mumble, your mouth opening is really small and you hear a difference in the resonance. Well, the thing about it is when we have sound that's going through the nasal cavity and being emitted through these tiny little nostrils, it's going to be reduced as opposed to when the sound is emitted through a big mouth. Okay, does that make sense? So low volume is one of the major characteristics of hypernasality. All right, so the vowels are nasalized and there's low volume. The other thing is we have voiced plosives. A plosive is a sound where you stop the air and let it go. So it's like p, b, t, d, g. A voiced plosive is b. The voiceless plosive is p. Okay, it's the same in your mouth, but one is voiced and the other is not. So voice plosives, the difference between an M and a B is the velopharyngeal valve. That's how we make those sounds sound different. With our mouth, it's exactly the same. So if I'm trying to say, buy baby a bib, and I have an open velopharyngeal valve, it's going to sound like this. Same thing with N and D. It's produced exactly the same in the mouth. The way we produce them differently is with a velopharyngeal valve. So D is an oral sound and N is a nasal sound. So if I'm trying to say, do it for daddy, you're going to hear nanny. And in fact, in connected speech, you're going to hear M's and M's throughout connected speech. But sometimes even the consonants that, other consonants that are not produced exactly the same can be substituted by a nasal phoneme. So if I'm trying to say, I see the sun in the sky, and I have no airflow in my mouth, this is what it's going to sound like. You don't hear the S's. So what I might do is compensate for that by using a sound that is a tongue tip sound, like an S, but it's a sound that I can produce with VPI. So I might say, I, ni, nun, in the nine. That increases the intelligibility of the speech, but it's a substitution. It's a compensatory substitution. Now, this is a child who has 22Q, and she has a lot of hypernasality, and I want you to listen to the prevalence of M's and N's in her speech.
Okay, Sarah, say, put the baby in the buggy. Take Teddy to town. Do it for daddy. I eat cake and ice cream. Go get the wagon. I see the sun in the sky.
Okay, I think I made my point there. Now, what are some of the causes of hypernasality? Well, of course, we know about velopharyngeal opening. That's going to cause hypernasality. But one thing you may not realize is that when there's a thin velum due to a submucous cleft, that can also cause hypernasality. Now, the reason is that as, let's just say, here's the velum, here's the back wall of the throat, as the air and the sound come up this way, or this way, I'm sorry, the tongue may elevate a little bit and push the sound, or compress the sound. And so some sound will go through a thin velum. In fact, actually in normal speech, when we produce vowel sounds, there is some nasal resonance on those sounds. There's more nasal resonance on an E than an ah, because the tongue is higher on an E, and that compresses that area and increases the sound pressure level. All right, so we know that anyway. But if there's a thin velum, then you're going to hear a lot more hypernasality because of that. All right, a large palatal fistula, obviously this is going to cause some problems, but it can be just misarticulation. I've had patients that come in and they use an NG, which is a nasal sound, for an L, which is an oral sound. So when they say, look at the lady, it sounds like, look at the lady. So you think that they have VPI, but they don't. All right, hypodasology sounds like this. This is when you don't have a nasal resonance on the nasal sounds. Now, what are the nasal sounds? M, N, and NG. And so what happens is the opposite occurs. That occurs with hypernasality. So now nasal sounds are going to be similar or sound similar to their oral twins or cognates. So if I'm trying to say, my mom made lemonade, a nasal sound, but I have hyponasality, you might hear, but Bob made lemonade. All right, if I'm trying to say, not now, Nancy, it's going to sound like this, down, Nancy. All right, and this will also even affect vowels. So here's an example of a young man that had a pharyngeal flap. He was overcorrected, and this is what he sounds like.
So my mom made lemonade.
I made lemonade. It's hard for me. Like when I do that, I should push it out. So it just excuse me. I'm sure it doesn't sound great, but it feels.
Feels weird, yeah. So causes of hyponasality, of course, enlarged adenoids is one common cause, or nasal congestion or obstruction. But the other thing is kids who have a history of cleft of both the primary and the secondary palate oftentimes have midface retrusion. And when they do, it affects the depth of the pharynx and the size of the nasal cavity. The size of the nasal cavity, if you think about it, the nasal cavity is like the upstairs apartment and the oral cavity is like the downstairs apartment. So the floor size of the nasal cavity is restricted because the ceiling size of the oral cavity is too short. All right, and that really does affect resonance. And then, of course, as this previous patient demonstrated, surgical correction of VPI is a common cause, unfortunately, of hyponasality. Now, cul-de-sac resonance is a little tricky, and a lot of speech pathologists have problems with this, especially if they don't deal with resonance disorders. So what happens with cul-de-sac resonance is that the sound resonates in a cavity, either the oral, pharyngeal, or nasal cavity, but it can't get out. There's a blockage at the exit of that cavity. All right, so here's an example. You're going to hear that this patient sounds, his speech sounds very muffled and indistinct.
Okay, ready? Count from 60 to 70.
60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
Okay, count from 1 to
Okay, there are three types of cul-de-sac resonance because we have three cavities in the vocal tract. So the first type will be oral cul-de-sac resonance. Oral cul-de-sac resonance can be due to microstomia or locked jaws, where the patient can't open the jaws at all. So it sort of sounds like this. You can hear a reduction in the volume of my speech and just a difference in the resonance of the speech. Okay, so this is the same as mumbling. You know, when kids mumble or an adult mumbles, they don't open their mouth very much. And you can hear a reduction in the volume and even the clarity because you can't get the pressure consonants out very well. Now, nasal cul-de-sac resonance is something that we see in kids who have a history of VPI or cleft palate. They have VPI, but they also have a blockage at the exit of the nasal cavity. And the common cause of that is a stenotic nares. So let's say the patient has hypernasality. Like this. If I block one of my nostrils, it's like this. Like this. Cul-de-sac resonance sounds like this. So there's more sound coming through my mouth, which makes it easier to understand. Now, both of the nostrils are blocked. Then this is what happens. And this is cul-de-sac resonance. All right, and that's what we were hearing with this one patient. And then pharyngeal cul-de-sac resonance is an interesting one. It's always caused by enlarged tonsils. So you can see these tonsils here. Now, normally, if there weren't tonsils, this opening from the pharynx into the oral cavity would be all the way around here. So we would have a good opening to get that sound from the pharynx into the oral cavity. Unfortunately, when the tonsils are large like this, now we only have a little tiny opening here. So most of the sound and the airflow is blocked and stays in the pharynx. So this is the way the speech would sound. It's very muffled, it's low in volume, the consonants are difficult to hear. The consonants are difficult to hear because the airflow isn't getting through there for us to use the airflow to develop pressure for those consonants. And so obviously the treatment of this is tonsillectomy. By the way, the problem with speech isn't the only problem that this child would have. Try to think about trying to get a hamburger down there. I mean, it would be really hard to swallow and get the bolus through that small opening. All right, now I want to talk about the presence and audibility of nasal emission. So with nasal emission, we go back to the physics of airflow. So as I said before, airflow continues in the same direction unless something blocks it. And if there's nothing there to block it, it's going to continue. So whenever there's an opening, even if there's a very small, tiny opening, it will be symptomatic. All right, so what does nasal air emission seem like? All right, if I'm trying to produce sounds, these are, we've got different sounds here. Plosives, they're sounds where we stop the air and let it go suddenly. So, p, ba, t, da, k, ga. Then there are fricative sounds. We also need airflow for that, but we even need more airflow for this because we need to continue the flow of air for a second. So that would be f, z, sh, and even zh, like a measure, ja. All right, and then affricates. An affricate is a combination of a plosive and a fricative. So if I produce a T and an SH at the same time, it's going to sound like this. Or if I produce a D and a ZH at the same time, is a J. All right, so here's the thing, is because these require a lot of airflow, these are the consonants that we will evaluate for nasal air emission. Now, typically what we'll do is not evaluate the B, the D, or the G, or the V, or the Z, or the J. The reason for that is that those are voice phonemes. So if I'm trying to listen to nasal emission on a B, I'm going to hear the sound. I'm not going to hear the friction of the airflow because the sound is going to mask that. The other thing is that there's actually more airflow on voiceless sounds, p, t, k, f, s, sh, ch. There's more airflow on those sounds because the glottis is open. It's wide open when we produce those. So all the air goes through there without any attenuation, as opposed to the voice sounds where the vocal folds are vibrating and reducing the amount of airflow that goes there. So when we do an evaluation, we're always going to listen to voiceless consonants. Now, because a p is really quick, that's hard for me to sort of figure out, was there nasal emission or not? So I would prefer a long sound. And so we typically use the S sound, because it's a continuant sound. All right, now nasal emission can occur with or without hypernasality. Now, there are different types of nasal emission, and it all depends on the size of the opening. So with a small opening, the airflow goes through there. It goes from a large cavity into a smaller area. And what that does is it increases the pressure of the airflow and also the velocity. So when it comes out on the top of the velopharyngeal valve, it comes out with a lot of pressure. And we all have secretions on top of our velopharyngeal valve. Sometimes we have more than others, but when there are secretions there, what happens is the secretions start to bubble. And just like if I use this and I blow through the straw, causing bubbling, you can hear that. In contrast, with a large opening, the air goes through with relatively less pressure. And so we may not hear it at all. It may be inaudible. So to give you an example, if I was saying something like, I see the sun in the sky, this is what you would hear. You don't hear the air going through there, but it's definitely going there because there's not enough air to produce those S sounds. Okay. All right. So nasal emission with a small opening. What that does is if it's a big opening, we don't hear it at all. If it's a medium-sized opening, we may hear the friction sound of the air going through the opening. If it's really small and causes the bubbling of the secretions, then we definitely hear that. That's very audible and can be very distracting. So with nasal emission in a small opening where we have the bubbling, we call that either nasal turbulence or a nasal rustle. It may not occur in short utterances or with effort. The child may be able to get closure in a short utterance or when he's trying really hard. However, it will increase with an increase in utterance length, phonemic complexity, fatigue, or congestion. The distortion is really loud and distracting. So I used to think that because the child could close the velopharyngeal valve with effort, that I could correct that in speech therapy. And the fact of the matter is I could correct it in speech therapy. However, as soon as they walked out the door, they still had it. And it's not realistic to expect the child to exert so much effort and really pay attention to his speech all the time. Therefore, even with the small openings, they require surgical correction. So here's an example of a small gap. You're going to see actually several small gaps here, and you're going to see the bubbling and you're going to hear the distortion. The audio isn't the best on that one, I'm sorry. Okay, now when the airflow is inaudible because of low impedance to the flow, it will mask, the sound of hypernasality will mask the audibility of the airflow. However, it will cause the consonants to be very weak or omitted. It sounds like they're omitted even though the child is trying to produce the sound, and that's due to a lack of oral airflow. The other thing is that because the child has such a leak and is losing air through the nose, they run out of breath. And so what happens is, like, I can count from 1 to 10 easily on one breath. But if I have an open velopharyngeal valve, this is what's going to happen. And I'm out of breath. Okay, so the other thing that a large opening can cause is a nasal grimace. And this is the grimace here. Sometimes you see it here, sometimes you see it here, or sometimes you see it in both places. What this is an overflow action or reaction to extreme effort to try to get that closure and to try to get sound and consonants out of the mouth. So it's the same as if I was trying to pick up something very heavy. You might see me go like this. Interestingly enough, if I see a child who has this, I don't have to do anything more because I know this child has a large velopharyngeal opening and needs surgical correction. Now, when you have a large opening, a lot of times kids develop what we call compensatory articulation productions. And the reason they develop these is to increase the intelligibility of the speech. All right, so we'll talk a little bit more about that in a minute, but I first want to show you this video here. This girl actually has velopharyngeal incompetence due to cerebral palsy, but it doesn't matter. It's sort of like the same thing. The cause is different, but the symptoms are the same. So she has very large opening. You're going to see that she has a nasal grimace. She has hypernasality, nasal emission, weak consonants, short utterance length, and low volume, in addition to the nasal grimace.
From 60 to 70.
She's taking a breath before each number.
Okay, now I want you to just make an S sound and make it as long as you can. And again.
She can't do it. She doesn't have the airflow. By the way, she had a microphone on and I didn't. So you notice the low volume. All right, so now let's talk more about the presence of what we call obligatory distortions and compensatory productions. Okay, obligatory distortions. This occurs when the function, in other words, the articulation placement, is normal. So everything that the child is doing is perfectly normal, but the distortion is due to the abnormal structure. All right, now the abnormal structure may be VPI, Or it may be malocclusion, like a class 2 malocclusion or a class 3 malocclusion, where that changes the placement of the tongue under, or it affects the tongue to alveolar ridge relationship, which is critically important for speech. And a distortion can even occur due to a tongue or due to a tooth that is misplaced and interferes with tongue movement. So we can't correct this in speech therapy because this is a structural problem, not a functional problem. Instead, the treatment is to correct the structure. Now, some examples of obligatory distortions include hypernasality due to VPI, or even nasal emission due to VPI. We can't correct VPI, which is a structural abnormality. Another thing would be nasalized voice consonants that we were just talking about a little bit ago, or even a lateral lisp due to interference of the teeth, where the tongue is in the right place, but the teeth are in the wrong place and interfere with the airstream. All right, now in contrast to that, we have compensatory productions. Now, compensatory productions are when the function, in other words, the articulation placement, is abnormal. And it's abnormal because of the abnormal structure. So placement is altered to increase intelligibility. And again, this can be due to VPI or malocclusion or an abnormal position of a tooth. So in this case, the treatment would be to correct the structure first, which is the cause, and then to do speech therapy to correct the function. If we try to do speech therapy when the cause is still there, it's worthless. We can't correct it as long as the cause is still present. So the structure needs to be normalized, and then we can correct the function. Now, some examples would be producing an N for an S, or pharyngeal fricative for oral sounds to compensate for the lack of oral sound and airflow due to VPI. Or another compensatory production would be what we call a palatal dorsal production. That's when the mid part of the tongue is used against the alveolar ridge instead of the tongue tip. And this is often due to a class 3 malocclusion or interference of the teeth. Now, interestingly enough, compensatory productions for VPI are all produced in the pharynx because that's where the airflow is. There's no airflow in the mouth, so the only thing the child can do to increase intelligibility is to produce the sounds in the pharynx where the airflow is. So compensatory productions include glottal stops. This is a type of sound. So if I'm trying to say bye baby a bib, it's going to sound like bib. All right, a pharyngeal plosive. This is when the back of the tongue goes back against the pharynx to achieve a sound that sounds similar to a K or a G. So it's sort of a gulp type of sound. Now, one common compensatory production is a glottal fricative, and that's an H. So an H is produced at the glottis. The air goes through the glottis and you hear. So if I can't produce a and say, I see the sun in the sky, I might go, I see the hun in high. So we've got a friction sound there. Now, a pharyngeal fricative is a, so it's produced by making the back of the tongue go backwards to create a small opening between the back of the tongue and the pharynx, and that's the way you can produce a friction sound. And then finally, the posterior nasal fricative is produced by producing or putting your tongue up against the velum like an NG and then forcing air through that. So you hear. All right, so because these sounds are produced in the airflow has to be released somewhere, right? Or your head's going to blow up. So it's not going to turn the corner and go into the oral cavity. What it's going to do is it's going to go up into the nasal cavity and there will be nasal emission. Now, if you do surgical correction of VPI, it's not going to change what the child has learned to do to produce these sounds. And so therefore, if they were producing any of these compensatory productions before the surgery, they will continue to produce those sounds after the surgery, and there will continue to be nasal emission. Now, in this case, speech pathologists can correct this type of nasal emission because now we're going to take this compensatory production and get rid of it. So we're going to change the production from the pharynx to the oral cavity. When we do that, if the VPI has been corrected, then just the change of placement will eliminate the nasal emission. I hope that's clear, and it's an important fact because if you hear nasal emission after VPI surgery, it may be because the child is still producing one of these compensatory productions. Now, an interesting thing, I think, is going back to the laws of physics, is that speech pathologists can predict the size of the velopharyngeal gap based on the perceptual features. So if there are the features include hypernasality, that's going to tell you it's a big opening. Whenever there's hypernasality, it's a pretty big opening. You will not hear the nasal emission because you're just going to hear the sound going through there, not the airflow. However, because there's going to be a lot of airflow going through the gap, the consonants are going to be weak in intensity, or it's going to sound like they're omitted. Utterance length will be short, just like that one patient where every number that she produced, 60, 61, 62, she had to take a breath before each one because she was losing so much air through the nose. You may have a little bit of audible nasal emission, weak consonants, and you may have compensatory errors. All right, now, the smaller it gets, the more you're going to hear the nasal emission and the less you're going to hear the hypernasality. And finally, if it's really small, even pinhole, you're going to have normal resonance. That's not going to be a problem, but you're going to have an inconsistent nasal rustle or turbulence. So a lot of times when we look at outcomes, we just look at hypernasality. We meaning the general population, not me. It's, you know, everybody looks at, well, we reduced or eliminated the hypernasality. It doesn't mean that you corrected the speech, because what you might have done is made the opening smaller, but now we hear the nasal emission more. And if it's a nasal rustle, nasal turbulence, it's loud and very distracting. All right, so this is ironic that if you have a small opening, you have very little hypernasality or no hypernasality actually, but you're going to have a lot of audible nasal emission. The opposite is true with a large opening. So now we're going to hear the hypernasality, but you're not going to hear the nasal emission. So if you're going to have VPI the rest of your life, you want a medium-sized opening. That's ironic, don't you think? All right, now, so the pre and post-operative assessment of primary cleft palate surgery and VPI surgery. We've talked about the speech assessment and some of the things that we have to look at when we're coming up with a recommendation for treatment. What we didn't talk about is the objective assessment and the visual assessment of velopharyngeal function. Now, the only objective assessment that is really useful is nasometry. And I have to tell you that I'm a big fan of nasometry. What it does is it actually measures the acoustic correlates of resonance and VP function through this computer-based instrument. And it provides objective data. The computer does not lie, it doesn't fudge the data, it's very objective. And we can compare that data that we get from that patient with standardized norms. All right, so what the nasometer does is it collects the sound coming from the nasal cavity through this microphone and the sound that comes through the oral cavity through this microphone, and it gives a percentage of nasal over oral. So the higher the score, the more hypernasality or nasal emission there is. The lower, it may be normal, or it may be that the patient has hyponasality. And we even get a nasogram, and so we can see here that this is normal resonance for oral sounds. You can see that there is some nasal resonance on the vowels. That's normal. This is not normal. This is hypernasality due to VPI. So this is a really great objective measure of surgical outcomes. The other type of instrument that I like to use is the nasopharyngoscope. So nasopharyngoscopy is when we take the scope into the middle meatus and then periscope down so that we can look at the nasal surface of the velum, the posterior pharyngeal wall, the lateral pharyngeal walls, and we can even see the opening to the eustachian tube. And we can see that, the patient can see it. The nice thing about this is that we can move the scope all around to see all aspects of the velopharyngeal valve. Now, back in the day, when I first started in my practice, we used video fluoroscopy exclusively. And then when nasopharyngoscopy came available, we used both. And finally, we stopped using video fluoroscopy because we found that it wasn't telling us anything that we didn't know through nasopharyngoscopy. The big advantage of nasopharyngoscopy is that you can see the entire velopharyngeal valve and all the structures around it. So you can see the structures on the posterior pharyngeal wall. We can see the nasal surface of the velum and determine if there's an occult submucous cleft. We just see a lot, and we can see everything, and it's in living color. We don't need 3 views to see all the structures. Another really big advantage is that we can see small openings with excellent resolution. And even if we can't see the opening itself, we can see bubbling on top of the opening, which tells us that there's a leak. The problem with video fluoroscopy is that if you've got closure anywhere along the plane, the beam goes through there and it takes a sum of all the parts. So if the velum is closing just on one side, it looks like it's totally closed, and you don't see small openings at all. The other thing is nasopharyngoscopy doesn't require radiation or barium. I think it's less traumatic for the child than putting the barium in the nose. I know from personal experience when I did some teaching tapes, the barium burns. And then if you cry, the tears wash it out and you have to put more barium in. The other thing is that the parent can hold the child during nasopharyngoscopy. So I think the 2 best instrumental procedures that we have in speech pathology include nasometry and nasopharyngoscopy. All right, so now let's talk about treatment. So with treatment, the first thing is that we need to make a differential diagnosis. That is really critical. The type of VPD and the cause will determine the appropriate treatment modality. Okay, so if there's velopharyngeal insufficiency, we can't correct that in speech therapy. We really don't want to use a prosthetic device. So surgery is our best bet for correction of the structure and normalizing the structures. Velopharyngeal incompetence, our first treatment modality would be a palatal lift to hold the velum up. Now, I've had several patients that had good speech articulation, but the velum just didn't move. They didn't have any reasons or medical issues that prevented us from considering surgery. They ended up having surgery. In all of my experiences, it was a pharyngeal flap, and it made a world of difference in not only their speech, but their life. So surgery can be considered in some kids with velopharyngeal incompetence. And then finally, velopharyngeal mislearning. Obviously, speech therapy is the only treatment modality that should be considered. All right, so let's talk a little bit more about treatment for VPI. One thing that people don't understand, and I keep saying it over and over, speech therapy can correct abnormal speech sound placement, including the compensatory productions that cause nasal emission. Again, speech therapy cannot correct VPI because that's a structural problem. VPI requires surgical or prosthetic management. The speech pathologist and surgeon need to work together as a team to determine what's going to be the best surgical procedure for each individual patient. All right, so actually I just said that. We need to work together as a team. So what are the surgical procedures for VPI? Well, these are the surgical procedures that I have a fair amount of experience with. So I will tell you, I worked for many, many years at Cincinnati Children's, worked very closely with the plastic surgery and ENT department, and we worked to find solutions for patients who had VPI. And basically, our strategy throughout most of my career is you find the hole and then you choose the best procedure to fill that hole. Now, the best way to find that hole was not video fluoroscopy. You couldn't really tell the location of the opening very well. So we use nasopharyngoscopy to find the hole and then select a procedure that would fill that hole. All right, so when we chose the procedure, we considered the size of the opening, the location of the opening, the cause of the opening, and of course, the history of upper airway obstruction. All right, again, these factors are best determined by nasopharyngoscopy. All right, so let me give you a couple of examples. Here we have a couple of small openings. There's a small opening right there. A pharyngeal flap would be overkill. I think a sphincter would be overkill. And the same thing here. We've got bubbles here. So it tells us that there's an opening, even though we can't actually see it, but the opening is right here. All right, so we would consider a pharyngeal augmentation for something like this. All right, now here we have narrow coronal openings on both sides. A pharyngeal flap, if you put a pharyngeal flap in this patient, those lateral walls are not going to move, and you're going to have persistent VPI. Same thing here. You put a flap here, and you're going to have an opening in the lateral ports. So what we would consider would be a furlough Z-plasty or a sphincter pharyngoplasty, which makes sense because the sphincter closes laterally and gives you a little bumper on the back. All right, now this is a good example of why you need nasopharyngoscopy. You can see that there's complete closure of the velum against the posterior pharyngeal wall. If you did video fluoroscopy, it would look like there's complete closure because, again, the beam takes a summary of the parts. And the same thing here. We've got a small lateral opening, but closure here. So video fluoroscopy would lead you to believe that there's total closure, but there's not. So in these cases, we would consider a sphincter pharyngoplasty or pharyngeal augmentation. By the way, I do not like sphincter pharyngoplasties for cleft palate because the problem is it leaves an opening where the opening already was. But the sphincter does make sense for lateral openings. Now here we've got central openings or a large opening. All right, so if you did a sphincter, that would be ridiculous because the patient is closing laterally. The problem is in midline. And if you did a sphincter, that problem would persist. The same thing here. It would close here and here, but you're going to still have a big opening in midline. So our go-to surgery was always a pharyngeal flap in these cases. All right, now there's some risks with these surgical procedures, as you all know. And the risks are that there can be undercorrection, which causes persistent VPI, or overcorrection, which would cause hyponasality, upper airway obstruction, and obstructive sleep apnea. All right, so what we like would be the buccal flaps. So the buccal flaps work for any size, any location, and has a history of a lot of success. Now, the advantages include the fact that it reduces the need for imaging, is less likely to cause upper airway obstruction, and is closest to normal physiology. Now, timing of speech therapy, I know I'm running a little over. I didn't realize I was, I'm sorry. Speech therapy and then VPI surgery, or VPI surgery and then speech therapy. Speech therapy is ineffective in the presence of moderate to severe VPI. So VPI needs to be corrected first. and then we can correct the additional compensatory productions. Now, the ultimate goal of surgery should not be any of these things. It should be normal speech. So our aim is to achieve normal speech. Parents want normal speech, not improved, acceptable, or adequate. Now, to compare ratings of severity is difficult, and we really can't do it. Judgment should be black and white. So we need to determine what works and what doesn't work and what is best practice. So this is what I'm going to suggest, that our goal would be normal resonance and no audible nasal emission as determined by an SLP, and nasometry values for oral sentences that are under 22%, regardless of language. If we do this, then what happens is we can compare the percentage of patients who meet the ultimate outcome of success, and we can determine those procedures with best results for benchmarking and teaching. Comparing outcomes effectively can result in improved outcomes for patients in the world. If you need more information, I have a textbook with lots of videos and all kinds of resources. And I want to thank you for your attention and for caring about these children.
And that was amazing. Thank you. And don't worry about running a little.
I want to apologize. I thought I was right on time, and then I just looked at the time and I'm way over, and I am very, very sorry.
No, don't be. You managed to give so much of information in the time you used, and it was very comprehensive, although it overran a little bit. I think a lot of surgeons don't understand a VPI or the nuances in the speech pathology, and I think you very, very well explained the differences and also how the differences in the underlying problem also guide you towards a solution. So thank you. Excellent talk.
Thank you.
Gosla.
Gosla, I apologize.
Absolutely, Joanne. In fact, you made my lecture much more easier. In fact, I learned a lot, especially the real. Now I know to be a good VPI surgeon, you have to be a good speech pathologist first. Then only you can be a
100% true. Yeah, you need a good speech and language therapist.
Yeah, you
do. About getting the exact diagnosis is important. Without a good diagnosis, I think there's no way we can correct it surgery. Yeah,
absolutely. Well, what people then fall back to is a standard answer to all the problems, and that's a bit of a hit and miss situation, isn't it?
Yeah,
true.
Yeah.
Right. Part two, Gosla. Thank you.
Thank you. Thank you. Yeah, please, Anne.
I just need to stop sharing my screen. Is it still showing?
It's done. No, I've already passed it on to Gosla.
Perfect.
Thank you.
Perfect.
Yeah. First, I would like to really thank Professor Anne Kummer for giving such a wonderful insight about the speech pathology in cleft lip and palate care and the VPI management. In fact, this makes my lecture much more easy because I'm going to really touch upon a very few points on the intricacies of the surgery, what as a surgeon we would need to really look into it. As she already mentioned, what is the velopharyngeal mislearning is, velopharyngeal insufficiency, velopharyngeal incompetency. There's nothing much I should talk about it. There are only two small things that I would like to stress upon as a surgeon. We always speak about is velopharyngeal insufficiency is what we look as a surgical point of view. The velum is too short to achieve the velopharyngeal closure during speech. So a short palate means that yes, the patient has a velopharyngeal insufficiency. Yes, when the velum does not move at all, like it's stiff or tight and then not only short but very tight, then we call it as velopharyngeal incompetency. Now, why does VPI occur? We know it is a structural defect. It could be a neurological disorder. It could be any other causes, or even a genetic conditions can lead to all these sort of insufficiencies and also to incompetency. Now, the structural defect, even a primary palate, when you look as a surgeon, as an experienced surgeon, you know that the soft palate is short. Even though you have a good adequate tissue, as you see in the hard palate, a good amount of quality tissue you see in the hard palate. But when it comes to the soft palate, you can see that there is hardly any amount of soft palate extension. It's immediately bang right ending into the uvula. You know that this is the patient. You have to try to see how much maximum you can stretch, elongate the soft palate by using the surgical principles. And also especially in isolated cleft palates, you can see the amount of scarring here, and probably this was already pre-operated and then broken down the soft palate and leading to a severe scarring, and then leading to what you call as a more of a scarred palate. Then again here in isolated cleft palate, where you can see even though the hard palate is not much extensive to do, but the soft palate is very short, especially in the submucosous cleft palate. You can see anatomically itself there is a huge gap and there is a severe insufficiency because the palate is short. And the evaluation of VPI, it could be objective and subjective. Yes, the thing most important is we need to keep ourselves a very objective identification of this VPI. Nasometry and nasoendoscopy are the state of art, which basically gives you a correct and accurate diagnosis. It's not about seeing a two-dimensional picture where the velum is the closing, but most important, the lateral port. The closure of the lateral port where you have the two bilateral coronal leak of the air in the coronal section, or the coronal or bubbling, what we call. In this situation, video fluoroscopy does not give you a good picture. So endoscopy or the nasoendoscopy is the accurate method to identify and diagnosis for what you call having a VPI. Subjective, like an hypernasality by listening to the speech assessments and nasal air emissions. Nasal air emissions are quite routinely done commonly in the OPD clinic, like using a mirror test or an air paddle or a stethoscope, or even trying to see if there is a nasal cordula sac speech type of thing. But the nasometry, this is the state-of-art equipment. As Dr. Ann Kummer mentioned, computers don't lie. They give you the exact picture. They give you the ratios of where exactly how much leak and what is the thing that is going on there, but it doesn't give you a three-dimensional picture. For this, we have to do what you call as nasoendoscopy. In fact, I was fortunate to be trained by Paul Welling and by Ann Kummer way back in 2007 and 8, and we do extensively only nasoendoscopy in our unit for identification, diagnosis, and management of VPI in secondary cleft palates. The VPI correction, yes, the surgery for VPI, as we mentioned, it should be palatal lengthening or a velopharyngeal narrowing procedure. Like a palatal lengthen could be a VY pushback procedure, a intervilloplasty, a double opposing Z-plasty. Whereas for the velopharyngeal narrowing procedure, it is a sphincter pharyngoplasty or a pharyngoplasty, which could be superior based or inferior based. As Dr. Ann Kummer mentioned, in cleft palates, sphincter pharyngoplasty has a very, very minimal role because it over constricts, or sometimes it might only constrict the lateral port, but again, what you call the central or the midline port may not be able to be closed by using a sphincter pharyngoplasty. So we have stopped using it more than 20 years back. We used it only initially in the starting part of my career around 25 years back. But in the last 20 years, I never used a sphincter pharyngoplasty. And of course, inferior based pharyngoplasty has been totally become redundant. No one uses it. Now it's called the superiorly based pharyngoplasty. In fact, we have added a component to it. We call it as a morphofunctional pharyngoplasty, which I'm going to explain exactly how it differs from the routine pharyngoplasty. The management of short palate is the most important, trying to do as early as possible in the primary lip repair itself. As you see here, you can notice that the soft palate is quite short. The distance between where the hard palate ends and the velum, that is the bifidness of the uvula, you can notice that it's quite hardly any tissue in between the hard and the soft palate area. It's very short here. So our goal is to really lengthen it and stretch it very much backward. So for that, what we use the standard Furlow's double opposing Z-plasty, as you see here. It is the gold standard method, and then we can easily using the double opposing Z-plasty, we can lengthen it. You can see the post-op picture of the same patient, even though here you can clinically visible what you call insufficiency is there. Here you can see as a clinical itself, the soft palate is very much pushed and stretched back and with a good functional uvula. And sometimes when you have a very short palate, and then especially in a very bilateral palates where it's not that we need to only push the soft palate backward, but we need to make sure the soft palate raises upwards superiorly and posteriorly. In the situation that we have to push the soft palate even more. So when you push your soft palate more, there is definitely going to be a more of a gap that happens in the buccal area between the superior limb and the inferior limb. So between these things, what we need to is we need to add some additional tissue. So the best method is to borrow the tissue that is very much adjacent to thing, that is the buccinator myomucosal flap. So we had to take a substantial amount of the muscle of the buccinator into the mucosal flap. I would explain the reason is when you are shifting and turning the flap, the key is the kink. If it's just a simple mucosal flap, the kink will reduce the blood supply and the chances of the failure of the flap is very high. So if you have an adequate amount of the muscle fibers into it, then automatically what it does is the kink resists the amount of blood supply to be cut off there, and it gives you a good blood supply there. Now, the real dilemma as a surgeon is when to do what and how to do what. Now, this I totally leave in the diagnosis of, and my speech pathologist dictates telling us exactly what we need to do and how much we need to do. It is solely responsible of having a good speech pathologist in your unit where they give you the treatment protocol. Of course, we can always say in any amount of things we can do a measurement. There is no objective measurement for a VPI. It's very difficult to get it. It is only by visualization and by the expertise of the surgeon, and most important, the expertise of the speech pathologist. Try to identify exactly where the leak is. It is a lateral, the middle, or all together as a single full coronal. Now, again, how much it is, large, medium, small. Now, how do you differentiate it? It's very, very difficult, because even though it's a very objective assessment, we do not have a clear-cut identification of measurement. Yes, in video fluoroscopy, there are studies that have produced what you call a CR ratio. Now, that is called the closing ratio. It is purely a two-dimensional. Now, we don't get the three-dimensional picture of the lateralization of the deficiency. You get only an AP deficiency. We don't get a transverse dimension and also the lateral dimension. We get only an AP dimension in a video fluoroscopy by utilizing the CR ratio. So it is a very, very subjective assessment. There is no way we can make out by using a video fluoroscopy. At least we can overcome this by using the video endoscopy by an assessment, saying it's a large, medium, or small. So we have made up a protocol stating that if it's a large, we do a Furlow's double opposing Z-plasty with using superior based pharyngoplasty. Whereas for the medium, we do a Furlow's modified Furlow's with levator myoplasty, or a Furlow's double opposing palatoplasty with or without myomucosal flap. If it is a very small, we do a simple straight line redo lip, redo palate with a levator myoplasty. This is what I'm going to explain you. What exactly is this modified Furlow's Z-plasty with levator myoplasty? Now, why Z-plasty? Of course, it has been proven very much in the plastic surgery principles that by using a Z, we can always stretch and lengthen any tissue deficiency. So when there is a VP gap of 5 mm or less than that, it is by using a simple single Z or a double Z, we can get a good adequate length. And with an increasing experience with the patient selection and modification of the design, however, the increasing the length up to 10 mm have been reported. Now, what we add is a very key component. We call it as a levator myoplasty. Now, the physiological orientation of the levator villi palatine muscle is the most important, that gives you not only the support to the velum to raise up, but also to stretch the length of the and making it more pliable and mobile enough to move backward. So we need to add both the Z-plasty and the myoplasty, and we have published it quite very long back by my colleague Dr. Rajgopal Reddy, and even Dr. Kummer is a co-author on this paper, where we call it as a use of modified Furlow's Z-plasty as a secondary cleft palate repair procedure to reduce the velopharyngeal insufficiency. Here, instead of using a double Z furlough Z, we use a single Z. Now it is a very simple design where it starts exactly at the junction of the hard and the soft palate on one side, the horizontal where with a 45-degree angulation, and then most important is the posteriorly where the velum is ending. That's where coming onto the uvula lies another horizontal flap. So it just rotates in a single format where we don't use the double opposing as we see in both the nasal layer and the buccal layer in a double opposing. Here we do it only in the mucosal layer. The nasal layer will be in the straight line. As you see here, we have opened up the soft palate in a very in a single Z. You can notice that the nasal layer is in a straight line, and the key is the levator myoplasty. The muscle of levator velar palatine is dissected right into its port, where it is in the canal. It is dissected. It's totally mobilized. The levator is dissected out from the nasal layer. You can see the bulging, and when you suture it together, you can see the amount of tautness it creates as what you call as a sling. The sling totally lifts the palate up, and then your modified Z pushes it for a lengthening. So the lift and the push gives you a posterior and a superior component movement of the palate. So the modified Z-plasty with levator myoplasty is what you can see here as an outcome. You can notice that a very short palate and a what you call as a bifid uvula here. So by using a single Z on the mucosa, and then there's a straight line in the nasal layer, using a levator myoplasty, you can see the tautness and the pushing of the total soft palate backward and upward. Now, whereas the furlough's double opposing Z-plasty has its own very good indications when there is a severe scarring, where there is no soft tissue left at the nasal area, we recommend to use it, go ahead and use the double opposing Z-plasty with most of the times with an interpositioning with a myomucosal flap from the buccinator. The simple reason is there's a huge deficiency of the gap that creates on the superior component of the limb. So that area has to be filled. So for which we do use the myomucosal flap from the buccinator side. So this is how it is done. And we make sure that there is hardly any kink on the lateral side of the mucosal flap so that it does not break down. And another thing is we always advise is trying to keep a couple of mattress sutures at all the junctions area. We take it down deep into the muscle, and then we attach the mucosal flap onto that onto the superior part of the mucosa of the palate, so that there will be no dead space between the muscle and the mucosal flap. And the morphofunctional levator myoplasty with superior based pharyngoplasty is used for all the large defects. It is as simple as what we mentioned, where we use either a most preferably is a single Z on the mucosa without putting any Z on the nasal area. We open up the soft palate. Now we raise a superior based pharyngeal flap raised above the prevertebral fascia. The key is trying to keep it as short as possible. There's no need for us to go very much inferiorly to raise the flap, because here what we are trying to do is, the key is we are not trying to stitch the pharyngeal flap into the nasal layer. This is what has been done standardly. Here what we do is we take the pharyngeal flap, insert it into the muscle. We put it directly into the muscle. So the pharyngeal flap is giving more stretch and strength into the levator myoplasty sling. So the sling which is already formed and the pharyngeal flap which is attached to the sling. So the sling totally is pulling the soft palate upwards and backwards. So we know most of the time the pharyngeal flaps becomes a pedicle. It becomes a thin thread or a tubing or any format, even though you try to do lining most of the time. So the best way to overcome it is putting the flap into the muscle. So when you put it into the muscle, automatically even though the pharyngeal flaps get shortened, or what you call becomes a pedicle, or it becomes a tubing, there is a stretch into the muscle. The goal is not to pull the soft palate, but it is to lift the soft palate upward and also at the same time to push it backward. This can be only attained by using what you call as a morphofunctional pharyngoplasty, where we take the pharyngeal flap into the muscle, not into the nasal layer. And then we can always close that thing, and we can see that using a simple morphofunctional levator myoplasty with superior pharyngoplasty, a good amount of stretch that is obtained here. And then this is one of the examples of clinical pictures what you see here, where we did a single Z, and push back the total soft palate using the levator myoplasty with the pharyngeal flap. I'll just like to take quickly on a few of the outcomes of the nasoendoscopy on the pre-surgery here.
వాడి డోరు కొత్తది లతకి కూర కావాలి రవి గుడికి పగలు వెళ్ళాడు చారు రుచి చూశారు సాయి తీసాతే రిషి షిరిడి వెళ్ళాడు
See, this is what you can see, a good closure in the endoscopy, and the same time I shown the clarity of the speech is a post. Now I take you to the pre, because once you know the clarity what it was, then you can see comparing to the pre.
రవి గుడికి పగలు వెళ్ళాడు
You can see the total opening of the port. This is the velum. It's not at all closing down in the middle. So this is another one where again I'll show you the post surgery.
టీవీలో పాటలు చూడు ఈ బాబు పేరు బాబీ కూర కావాలి తాతపై పేరు ఈ గుడికి వెళ్ళాడు
You can see pre-operatively there is a total opening here. Post-operatively it's closing very much.
సాయి తీసాతే
So the key principles to avoid VPI is intervalloplasty, reorientating and reconstructing the levator villi palatine muscle sling is the key. The most important is we don't touch the tensor villi palatini. We just leave it where it exactly it is. We just dissect it from the posterior component of the maxillary bone, the palatine bones, and just directly attach it. We don't dissect radical dissection of the tensor villi palatini. The tensor villi palatini should never be detached, should be never cut, or never should be isolated from the tuberosity or from the posterior component of the maxillary tuberosity area. We have to leave it in where exact position it is, because by reducing the tension, we lose whatever movement of the palate upwards is lost. So we need to retain it. We never do any radical dissection of the tensor villi palatini. We only believe in doing a very good radical muscle dissection of the myoplasty of the tensor levators only. Now again, achieving the adequate palatal length by using a single Z or a modified single Z or a double opposing furlough Z with or without using buccinator flaps, and minimizing the tension on the palate. These are the key principles to avoid the VPI. Now the soft palate dissection, as I mentioned, you can notice the tensor villi palatine is hardly touched. We don't do the dissection of the tensor villi palatine. We only dissect the levator myoplasty. You can see the tensor muscle is left intact here. We don't do it. Only it is just done a direct suture here. We don't release it. We don't do any radical dissection. So optimal muscle dissection of only the levator muscle bundle, we call it as levator myoplasty, and the tensor tendon is not dissected. This is what we call as morphofunctional palatoplasty and evidence-based recommendations, and we have published in a good number of series of outcomes in Journal of Oral and Maxillofacial Surgery in way back in 2016. So my recommendations, my dear friend, as we have seen exactly what is the role of the speech pathologist, what is the real importance of the speech pathologist in identifying the VPI. They are the key for identifying where the deficiency is, what is the type of the deficiency, what are the recommendations, that type of surgery if we do will be giving a better outcome. We had to rely on their judgment, and then we had to use our skills as a surgeon to work as a team together to overcome this sequelae of the primary surgeries called as the VPI management. So the key is primary palatoplasty. We have to use a strong principles. We use one-stage palatoplasty or a two-flap technique with optimal muscle dissection without touching the tensor tendon, keeping it intact, a furlough's double opposing Z-plasty, or especially in isolated and submucosous cleft palate, we have to recommend that. And for a management of velopharyngeal incompetency is modified furlough's Z-plasty with levator myoplasty, furlough's double opposing Z-plasty with or without buccal myomucosal flap, furlough's double opposing Z-plasty with pharyngeal flap are my recommendations for management of VPI to get this good smile back on our patients. Thank you very much.
Thank you, Gosla. And I'll switch on your a microphone as well.
Yeah, please.
And your camera, if you like. I'll leave that for you to do.
Yep.
Gosla, thank you. You did that in record time.
Yeah.
Well done. And still in a way that even people that have less experience with this subject were probably able to understand the keys to success in your talk. What it also shows, in my opinion, is where the teamwork comes in place.
Mhm.
Because there are some subtleties, some nuances you need to recognize. And as soon as it's obvious, most people will be able to produce the right answer about what to do. But to have a predictable result in most of your cases, you need the combined effort and the combined analysis. And I'm always amazed with my speech and language therapists, and I worked with a few. They hear things that even my ears after all those years still don't catch, and I don't know how they do it, but they do. The same with copying the sounds, like Anne did so wonderfully well in her talk. I can do hypernasality, and that's about where it stops. But you did manage to produce every one of those sounds individually very well, and that's expertise, and that's what you need in a team. I can see that a few people are already logging off. I will once again express that we're happy to receive questions. So if there are people that have questions that were raised during the talks we just enjoyed, please bring them forward. In my far more limited experience, I sometimes feel that the video fluoroscopy has only one advantage compared to the nasendoscopy, which is the better way to judge what's going on. Sometimes there's a subtlety to how much of an effort the muscle actually makes and where the bend in the palate takes place.
Mhm.
And there you need to weigh in whether you do the buccal flaps for lengthening and a bit more release for the muscles. And there sometimes I feel a video fluoroscopy has some added value. So we do it very rarely, but in cases where we're kind of like in need of a little bit more input to finalize the decision. But I agree otherwise with you that the other two ways to objectively evaluate a palate are far superior.
Mhm.
Not
Yeah,
sure if
I
you have anything on that.
definitely value. Occasionally, there are times that we have done lateral fluoroscopy so that you could see the whole line of the pharynx and you know, even see at what point they're contacting the pharyngeal wall. But the very vast majority of the time, we always use nasopharyngoscopy. That was our first. That was always the first thing we would do.
Yeah, no, I totally agree. And as you said, the comfort with the fact that you can keep the child on your lap as a parent also makes a huge difference. There's a question coming in actually to Professor Gosla. Let me try to read this out to you, Gosla. The question comes from Hatem. I can't read the whole name. Let me see if I can widen it a little bit here. Hatem Alamadi, thank you for your question at this hour. And Gosla, thank you for staying awake to answer it. So the question is, why furlough with pharyngeal flap, not intravelar with muscle myoplasty technique?
Thank you very much, Professor Hatim from Egypt. He's a very dear friend who visited us for some time. I'm sure he has seen a good amount of these pharyngoplasties done in our unit. Yeah, I do agree. Why double opposing Z-plasty and why not only a simple intervalloplasty? Yes, as I mentioned to you, if it's a very simple small VPI, we do only a straightforward straight line levator myoplasty. We don't even add a pharyngeal flap. Now, you need to understand the pharyngeal flap is definitely a very good tool for our surgical in the hands of surgeons. But at the same time, it creates a huge amount of issues, especially in younger children when you're trying to do it. Because yes, as the recommendations from the speech pathologist is to do it as early as possible. Definitely to do a video endoscopy or anything, it is between the age of above 5, 6, 7 is normally is a good time to do. Now, once you get your diagnosis, you need to say that, okay, you're going to do a pharyngeal flap or not. Now, if you do a pharyngeal flap, it's good for the early speech to develop and everything goes well. But at the same time, you have to understand the amount of trouble we are going to create on two things, that is on obstructive sleep apnea. Second most important thing is, the most important is it pulls your palate back along with the maxilla. So there will be definitely a severe amount of midfacial hyperplasia.
Yeah.
Now, we as a good surgeons, we know we can manage to move the maxilla any amount. But again, by moving it, like we had to depedicalize it. If you're doing it as a direct movement, we had to depedicalize it. If not, we had to use distraction, a midface distraction. Now, this decision we can only make after the growth is over. Now, we know the difficulties in doing a midface distraction, having this RED on the patient's head for nearly for 2-3 months, the psychological aspects. Yes, nowadays everyone say, let us do a bimax surgery, reduce the amount of maxillary movement, push the mandible and get the maxilla. Even then, the maxilla will be sorted out. Here we are talking about a 3-dimensional scar of the maxilla that is not only having the lateral transfers, but also the superior scars coming from the omerine down onto the palatal area. At the same time, you have one more scar band, that is the pharyngeal flap. So when you're trying to move it, it starts rotating. It doesn't sit, because even though you put it on IMF, the moment you release the IMF, the scar pulls backwardly and then it rotates here and there. You will definitely end up in losing the occlusion. So we always think that it's better to depedicalize the flap. Now, whatever you have done good for the speech all the years, by moving the maxilla bit forward, yes, again, we know that it is going to create a bit of insufficiency, not incompetency, insufficiency. Now, losing the flap again leads to definitely incompetency. So the chances are here. So it is a very balanced things to make as a surgeon to do a pharyngeal flap at early stages itself. So let us try to give a good amount of pushback. So instead of doing a just simple straight line without doing a double opposing, only thinking that your levator myoplasty or your muzzle orientation, what you call a radical muzzle orientation or anything, intervilloplasty, but pushing the flap backwards, the soft palate backwards is the key. It's not only about lifting the palate. So that can be only obtained by using a double opposing Z, or if not a single opposing Z. Any of these two, we had to stretch the palate and also additionally get the tautness and lifting of the palate by using the levator myoplasty. So I would not recommend to do a pharyngeal flap in a straight line closure using only a intervilloplasty. It is not advisable.
Thank you, Gosla, for explaining that. Yeah, Professor Alamadi already explained this question in a second remark, in a remark where he said that he meant a pharyngeal flap in combination with a furlough, why you preferred that over a intraveloplasty with a pharyngoplasty. But I think you answered the question. It gives that little bit of extra length and dimension you miss without the furlough. I hope I summarized it correctly.
Later for the future, for the maxillary hyperplasia.
Yeah, absolutely. Okay, any other questions from the audience? I get quite a few. Professor Alamadi responded. Yeah, he's answered the question. I agree. You gave a lengthy, very thorough answer. Thank you, Gosla. A lot of people give feedback that they really enjoyed the talk and that they were excellent. So just passing that on. Okay, well, thank you very much. I guess it's running a little bit late for everyone by now. I very much enjoyed both talks. I learned quite a few things, which I'm grateful for, and I'm sure the audience did as well. And I wish you a good afternoon.
Thank you.
Pleasure. Gosla, I wish you
Go to sleep.
exactly a good, healthy sleep. To the audience, have a nice remainder of the evening. And I would also like to take the opportunity to wish everyone a happy Easter and a enjoyable, prolonged weekend. And I'm looking forward to see everyone again in May for our first lecture from Turkey this year by Professor Hakan Tuz. So all the best for now. Good night,
Thank you.
Gosla, and happy
Thank
Easter to everyone.
Thank you.
Thank you. Take care. Bye-bye.